Hello and welcome to this webinar. My name is Imran Lasker, Dr. Lasker. I'm a consultant radiologist, and thank you for all the people that are turning up and slowly trickling in. Please do give me a hello. Can you hear me? Just give me a yes, no, whatever, just so I kind of have an inkling that there are people here, there are people listening and hopefully going to benefit from this webinar. So welcome to Radiology Seminars. Some of you guys have interacted with webinar Radiology Seminars before. You know us quite well. You may have seen me do various talks for Collective Minds Radiology, Everlight, I think Everlearning, Radiopedia. There's a few different places where I've done a fair amount of teaching. Sorry, I need to open the chat. So I'm going to open the chat. Let me just do that. Okay, so the three dots in the chat. So there's three dots in the chat. It's going to open the chat. Everyone. Okay, so hi everyone. Can everyone see that? I've opened the chat to everyone. Yeah, attendees can chat with everyone and panelists can chat with everyone. Great. Okay, great. Thank you. Sorry about that. I thought it was open. Oh yeah, Anna, how are you doing? Welcome. Thank you. So what we're going to be doing is going through some kind of basic principles to try and help anyone that is interested in CT imaging. It doesn't matter which like stage you are in your training, whether you're a radiologist, radiographer, someone who's an A&E, and you know, thinking about looking into taking up a career in radiology, or you're looking at the scans and you want to learn a little bit. So I'm going to kind of give away a few little secrets here and hopefully kind of get you to you know, consider signing up to our course coming up. So first off, introduction to myself. My name is Imran Lasker. I am a consultant radiologist and I work for Basden, which is part of the MSc group. I trained actually in London and I completed my training in Imperial, where I did loads of on-call stuff. Honestly, like I did those horrendous trauma nights, you know, trauma nights where big, you know, scans were coming in from people who've been injured quite badly and having to stay up all night, do the initial kind of talk through the scan with the entire team around me in the room, and then write a full report. And actually, to this day, I continue to do a lot of acute imaging, both in the MSc group and in other places as well. And then my colleague, Dr. Said Junaid, who won't be able to join us today, unfortunately, we both run radiology seminars with a big team behind us, and we've been doing this for a very, very long time. And the thing is, we started this whole radiology seminars a few years ago because we're really quite passionate about teaching, and we wanted to really bring something different to the entire radiology seminar sort of marketplace, and try and get people to really learn from radiology and be passionate about radiology in the same way that we're quite passionate about radiology. And I think we're doing that, we're getting there. And from the interactions of people and the people that work with us and who attended our courses before, I think we're getting there to a stage where we can actually expand a little bit and kind of start to bring more focus courses for people. There will be a Q&A for anyone that is interested. Hang on, let me just make sure that you guys can see my screen. You guys can see my screen. I'm going to try and bring that chat desktop to share. So can everyone see my screen now? I'm going to bring that chat here. Okay, chat here. Okay, so yeah, my name is Imran Lasker, and Said Junaid, he's a consultant at Bridgend Princess of Wales Hospital, and we've been working together on this for quite a long time. So the way it's going to work, I'm going to go through a few concepts. We're going to have a big Q&A session at the end. So if you've got any questions, regardless of what it is to do with imaging, anything really, even if it's a career in radiology, I'm more than happy to hang around and talk about those things as well. So it's kind of hopefully a bit of a chilled out session where we can kind of talk to each other. So I open the chat for anyone that wants to ask any questions during it. There's also the Q&A area where I will be picking up questions if anyone has any questions. If you don't want to be asking around to every single person, you want to kind of ask more privately, and I'll do my best to answer the questions as we go along. So we've been doing this for quite a while, and we've had hundreds and hundreds of people turn up to our courses, and we got some really, really amazing feedback over the years. And this one really stuck out to me. And it was a presentation. The presentation was delivered in a very approachable manner with explanations that are clear, not intimidating. And the content was comprehensive, informative, and the practice suggestions were clear, understandable, and something they can feel they can apply. And I think this piece of feedback really does kind of culminate everything that we've been working towards. We want to be approachable. We don't want to be intimidating. We want to have clear explanations, give comprehensive information, but not just give you information that, you just learn it on the day and you just move on. We're trying to give you sort of foundations so that moving forward, you'll be able to sort of learn on your own. It's a bit like, when you pass your driving test, you're good at driving, but you're not like, you don't know everything about driving. You're actually good enough to learn the rest on your own, which is pretty much what's happening. So new drivers, they'll have a few, knocks and stuff like that, hopefully nothing too serious. Same way with our courses, we try and run it so that we give you the foundations to be able to go forward and learn as much as possible. So as said previously, this is me looking a lot younger, minus kids, back in 2011, and I started radiology training around then. And I did a lot of on-call, both in this trauma center, like I mentioned before. And I found it really, really intimidating because obviously you never feel like you're really ready for this kind of thing. You never realize like how much your opinion matters, right? And big decisions are being made on whatever you're saying, and then I realized that actually a lot of this has to do with sort of exposure, how many cases you're being exposed to, practice. So you get into practice, looking at cases regularly, being honest with your feedback and really honest with yourself about how you're doing, and then getting feedback from people as well, like seniors and people who are who are further along the journey than you are, and then kind of improving on that as you go along. And I kind of came to these sort of big three realizations that there are like a few ways, 4 ways I pretty much identified that you could learn radiology, and you kind of got to choose the one is best for you. And then and number 2 is that, you feel like you got no radiology background, no experience of emergency, you're not enough, and you think it's really, really hard. But actually, and you think to yourself, I'm just going to learn on the job, but it's not the best way to learn. And there are better ways of doing it, or at least giving yourself the best chance to be as safe a clinician or practicing healthcare professional as possible. And then, secret 3 is just having the foundations and learning radiology, which is kind of one of the things that I really prefer to do. So I'm not saying by coming to the course, you will know everything, but you will have the tools to get to the point where you know everything. And so the 4 ways that I have identified that you can learn radiology, and you kind of got to choose the one that's best for you, is just to do more on calls, just do loads of on calls. But let's face it, on calls are, if you're training, you're training. If you're not, you're not. And how much time do you really want to put in doing night shifts and weekends and that kind of thing? There are better ways to be learning. And then, this is what I used to do before courses used to exist, before online courses used to exist, before on-demand courses used to exist. YouTube still existed, although sometimes it was a bit annoying because half the time the trust wouldn't allow you to go onto YouTube. And then on top of that, like the reception was really bad, so you couldn't really get onto the Wi-Fi or whatever, and it was just a bit of a mess. But you can go to YouTube and type in emergency radiology or whatever you're looking at, and that is not a bad place to go. But I found that YouTube is amazing, but it's difficult to really have like an organized way of learning. You're right, like, because you just find random stuff and you click on this video and you may have wasted 10 minutes looking at a video and realize actually that's not really helping me. You go to the next video and the next video. And so that's why you really want to go to a course and try and learn from that course and have like a really a good mentor, first of all, and also have like a succinct pathway, like a very definite way to go through things and build upon knowledge, but to the point that you're ready to learn on your own. And then there's the other way of learning, which is your peers. You talk to your mate, you talk to your senior on passing, you may say, oh, there's a really interesting case, can I show it to you? And that's actually a lot of the way that radiology, I feel like it is in some ways this, in some ways this, in some ways this. Like it's a combination of all of these things to get someone to be ready to be a radiologist or a healthcare professional who can actually interpret images. It's a combination of all these things. But the thing is, you're really kind of basing it on what's coming through that door. Like, are you lucky enough to have something very interesting coming through that door? How are you going to get that sort of curated case mix that you really want? And that's where I think, and this is where we fit in. We make these courses and we get like cases that are not like your standard cases. Not that, when you go to a textbook, you'll have perfect, pristine cases that literally show you everything. Like, this is what it is, this is what it looks like, and that's it, and you move on. But what we're trying to do is get you to the point where you're looking at something that doesn't quite fit the mold of appendicitis, but could be appendicitis, or something that doesn't quite fit epiploic appendicitis, but by all definitions is a epiploic appendicitis. And therefore, you've got to make that call. You've got to make that call in that particular situation. And so those are your 4 ways. And I think that courses are a really good way to go. And having been through a few courses myself, and how to look at the way they do things, I realized that actually there is a better way to do even the courses. And I think that we've really managed to do this, but do a really good job of this by doing the course that we have and the feedback that we've got. And so the thing is that the thing that people also worry about is like, you know, this particular area where people say, look, I don't have enough background. I don't have much experience in emergency imaging. It's too hard. And I just don't think I can do it. The thing is, like, yes, radiology is very, very broad. It's very, very broad. There's loads of things. There's loads of anatomy. But you have to realize that when you're talking about emergency imaging, there's only so many things that can really happen, right? So if someone comes in with an abdominal pain, it's going to be what? Acute cholecystitis, pancreatitis, a kidney stone. It's going to be diverticulitis, appendicitis, obstruction, right? Ischemia. And if you can rule out all of those things, then you're pretty much most of the way through when it comes to emergency imaging. And that's when you can start to actually learn quite a lot quite quickly and become quite competent. And think about it from this point of view. When you look at a radiologist in training, right? So it's a 5-year training program. When you get beyond year 1, all of a sudden you're on call. And so you've only done a year of training of a 5-year training program, but you're on call making these big decisions. And actually by that point, you are good enough to be able to try and basically, you know, identify those main topics. Is it obstruction? Is it perforation? Is it that? I'm going to go through a case to try and illustrate some of this with you in just a second. So what we've done is basically simplified the whole process, right? And tried to make it into step-by-step things. And we really do teach complex cases, but those complex cases are not textbook cases. And that's what we're trying to get you to, because no one comes in like a textbook. And this, you find that from the clinicians who are referring to you. They'll say something like, oh, well, they've got abdominal pain, which is in the left iliac fossa, but it turns out to be appendicitis in the right iliac fossa. So no one's really presenting in a textbook manner. And then what we've done, so all of our courses are very much built on the shoulders of giants, as it were, because previous attendees have told us what to do, where to improve, and how to do things. And what we used to do was do really big course with lots and lots of people. But we realized that actually, when you focus down on specific people coming along, we can really focus in on what their issues are, even with regards to manipulating the images, how to make the images look better, how to relate those findings, and all those kind of things. And that's why we kind of built this course to be even better and bigger than it used to be. And like I said, there's only so many things you really need to know when it comes to emergency imaging. And so now this is where we've come in with our course. We've got the foundations of learning radiology, and I am going to give you a case to look at now. And so hopefully everyone's got the, so everyone has got the, hang on. So everyone's got the, I'm going to just get the case out for you guys. I've got it in my notes here. And I'm going to put it into the chat. So what we'll do, we'll work through this together. So coming up in the chat now. And I'm going to give that to everyone. Okay, so can everyone click on this particular case? What I will do, I will open it on my window as well. So we use something called Collective Minds Radiology. If you do join our course, we would basically sign you up to this as well. It's free, so don't worry, we're not taking extra money from anyone or anything like that. It's just a really, really good platform. I work with these guys a lot in terms of the way it works and stuff. I don't do program or anything like that, but they're a really, really good team, and they've really made our courses go to another level. So a lot of courses will just sort of show you a few images and that's about it. But really, this one is a great way to be able to go through the cases yourself as well. So hopefully everyone can open that case and have a look. What you can do is, can you see I've clicked on that little cloud button? That cloud button will actually download it onto your computer temporarily, and then you should be able to scroll through a lot easier. So what I'd like anyone to do, if anyone's had the chance to go through it, do go through it and tell me what you think is going on. And for those of you that haven't been able to access the image, no worries. I'm going to go through it once, and then just feel free to just throw in your answers. So this patient has had abdominal pain. Okay. So let's scroll from the very, very top and all the way down, all the way down, all the way down, all the way down, like so, and right to the very end, or quite right to the very bottom. So has anyone seen anything that they think is a little bit untoward with this particular study? Can anyone see anything, say that they found anything particularly scary? Or is this a normal scan? Just give me someone, just give me anything. Nothing so far. Okay, well, what I'll do, I will start to roll through it and explain things as we go along. And if you do find the answer, if you do think you've got the answer, then just write it in the chat, and then we will, I will confirm, refute, and talk to you guys during it. So first off, what we're looking at is a CT abdomen pelvis. I mean, yes, we do have some of the lungs, which are here and here, but actually it is very much the CT abdomen pelvis, because it goes all the way to the bottom over there and all the way to the top. It just kind of has some of the lung, which can be quite useful because sometimes you'll end up seeing a nodule or something like that. Is this a contrast or non-contrast study? This is a contrast study because you can actually see the quite nice differentiation of the kidney parenchyma over there, and you can see the portal venous system. The portal vein is over here as well, and so you can see that's all kind of nicely enhancing as well. So a portal vein is over here, and that's all nicely enhancing as well. So you know that this is a contrast enhanced study, but is it arterial or not? So this is the aorta. You know, the aorta is coming from the thorax. If you're ever unsure, you can go from the thorax and then work your way down and then see that, yep, this is the aorta coming up from the rest of the body, from the chest. But if you're still unsure, then what you can do is you've got a vessel that's sitting over here and a vessel that's sitting over here, and the aorta is always on the left. I always think AOL, which used to be like an internet company back in the day called American Online. It's the only way to get on the internet back in those days. So aorta is always on the left when it comes to when it comes to the human body. So this is not an arterial phase image because this aorta is not as bright as the spinal vertebra on this particular window. And actually what you'll see is if you come up to the portovenous system, which is this thing over here, compared to here, this looks bright. This looks brighter than this. So therefore, this must be a portovenous image. Right. So we know that this is a portovenous image. And then what you need to do is think, okay, this person's coming in with abdominal pain. What can give us abdominal pain? Cholecystitis could. So where is the gallbladder? Gallbladder is over here. And looking at it, it actually looks very, very normal. So that's fine. The kidneys are sitting here and here. And they actually look very, very normal. They don't look like they're obstructed. It doesn't look like there's any inflammation around it. And inflammation would be, so there's fat stranding stuff around. So this is all fat. And you get the sort of strandiness all around the kidneys that would make you think that this is actually fat stranding and inflammation. But the kidneys look completely fine. The other thing that can actually cause abdominal pain is going to be pancreatitis. Now, the pancreas can be a bit difficult to see, but this leaf-like structure going along like so, I have to kind of zoom up and down to show you, I mean, scroll up and down like this, and going along like this, all the way along. This is where my mouse is, over here, like this. That's completely normal. It doesn't look like there's any abnormalities there either. No fat stranding around there at all. So, okay, so no pancreatitis, no cholecystitis, and now we've got to look at the bowel. And the best way to really look at the bowel is to really start from the bottom, quite literally, right from the very bottom over here, and work your way up. And I'm going to scroll up. And as you can see, we've come up to this point here, which is the rectosigmoid junction. We're going forwards. And then it feels like it does this kind of twisty maneuver, goes this way, and then opens up into here. So you can see it kind of does this, right? And then it opens up into this really large viscous over here. So what you've actually got, what looks like a kind of a twist. So if you keep your eyes in this area, you should be able to say, look, it's going to be over here. And if you kind of see that over here, it kind of swirls up and down like this. And the bowel looks very, very dilated after that. So can anyone tell me what that is? And if you can't, don't worry, I'm going to go through it anyway. So this looks very, very dilated, very, very big. This over here is this bowel over here is way, way too big to be normal. It just can't be. So then what we do is you click on to the coronal images. And when you scroll through, and if I go to the lung windows, which are over here, can you see this? This looks like a coffee bean. Look, this really does look like a coffee bean like this, right? And so when you've got it like that, exactly, someone's gone and said it. It does look like, yeah, exactly what you said. It looks like a sigmoid volvulus. And then what you can do is you can actually scroll through it some more. And what I really want you to do is pay attention to this one particular area. Will the recording be up? We'll most likely put it on our YouTube channel. So we've got a YouTube channel called Radiology Seminars, and you can go find it there later today, or later on. So then look, now when we scroll through, we will come up to the area of interest. Actually, look, we're going to have to do the cloud button. And can you see around here, if I put the little light bulb over here, can you see that? You can actually see it twisting around. Look, and look there, can you see that kind of going like this? If we follow that up, twists around like so, and that's called a whirlpool sign. You know, when you like let the water go down the bathtub, it kind of goes around like this. That's pretty much what you're seeing, but with the bowel. So keep your eyes over within this region. So this region over here. And then you can see it, look, swirl, 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 swirl. So this is sigmoid volvulus, right? So yeah, well done. A few people have got it. But then what's the next thing? So this is what we're trying to teach you on the course. That you've got sigmoid volvulus. Do we stop there? No, we don't stop there, because what we have to be thinking about is the complications of sigmoid volvulus. Someone could have ischemia. They could have a perforation because of a sigmoid volvulus. And that's what we will end up going through on this course, where we actually look through and make sure there's no ischemia, which is a slightly more complex area, and there's no perforation or anything like that on this particular study. But those are the next questions that we'd be looking to answer when we go through these cases. So you can see, hopefully, you can actually glean quite a lot of information from having kind of basic principles and then working your way towards like everything else. So at the very least, right, you can tell there's an obstruction of some sort. You can tell there's no, well, you will be able to say there's no perforation and no ischemia. And it's pretty much most of the things that you want to be doing when you're in the middle of a night shift, or when you're doing these on-call scans. And so why are we doing this? What's the bigger goal here? So as those of you that are radiologists, radiographers, or anyone that interacts with any sort of radiology, we've got another 2 good cases coming up as well, and a bit of a treat for anyone that sticks around to the end, by the way. So do hang around. We know that the numbers of scans are increasing massively. Like, we've got an increasing number of scans. You can go to the RCR website. They've put it all up in there. We've got more scans coming in. We don't have enough radiologists covering it, and that's resulting in big delays in management. And that can happen across the board over absolutely everything. The thing is, when it comes to emergency imaging, you know, what's the issue? What's the problem? And the thing is, like, you may feel as though you don't have enough knowledge. It's very, very complex, all of this stuff, and your opinion doesn't matter. But the thing is, like, your opinion does matter. It does. Even it doesn't matter where along the care chain you are, it does matter. So is it complex? Yes and no. If you work from basic concepts over a long enough period, with the basic foundations, you'll actually get really, really good. And the way I always tell people is that, yeah, a radiology registrar may see 10,000 x-rays over the 5 years, but over a lifetime, a radiographer will see 10,000 x-rays over a similar time, if not more, or if not less. But what's the difference? Like, you've got to, if someone is looking at the x-ray every single day, working from basic foundation principles of what a normal x-ray looks like and what pathology can look like, then within, very quickly, you can actually be on par with someone who's fully trained in it. And I really like it when someone calls me up and say, I missed something, because I think, okay, cool. It means that you're on the ball and you're interested. And then when you really focus your knowledge, right? And this is what I mean, like, if you focus your knowledge on acute imaging only, and for the beginning anyway, then that's all that's really required to be able to do quite a lot in the terms of acute imaging in the A&E department and that kind of thing. And your opinion can make a really big difference. I mean, if I think to the times when I was a registrar, you come in and there's like 20, 30 scans just waiting there. You think, oh, how am I going to get through so much work? And, there's case number 1 all the way to case number 30 or something, or case number 20. Number 18 might be the one that needs to be reported as soon as possible. And the times when you've got someone who calls you up, be it an A&E doctor, a foundation doctor, radiographer, and they call you up and say, listen, Imran, I think I spotted something here. Do you mind taking a look? That can make a massive difference to patients. And that's what it's all about. Trying to help people, trying to help patients, with their healthcare, get them cared for as quickly as possible. So hopefully I've got another 2 cases to go through, and then I'm more than happy to answer any questions that come up. So case number 2, let me just grab it. Oh, hang on, my case number 2 hasn't come. Let's go to case number 3. Is that there? No. Okay. So for some reason, my notes didn't come up there. Let's see if I can find it here. If not, I'm just going to grab it from my bank. So just bear with me for a second. If anyone's got any questions for now, then please do feel free to ask your questions. In the meantime, I'm going to just grab the case. So, I mean, the point is, like, what you'll find is that it's not that much knowledge that is required to try and get try and make the biggest difference to people. I mean, that's the truth of the matter. So, when you've got the situation where you've got ischemia, you've got these situations where you've got perforations, that kind of thing, and you think to yourself, I don't know that much. Well, chances are you'll know more than the person asking for the scan. That's the truth of the matter. Like, you'll find that you'll have more knowledge than the person asking for the scan. That sounds silly. It sounds a bit weird, but you'll find that in those situations, the problem is that you just, you're able to give more information than the person that is saying to you, look, I need the scan, and your small nugget information can make a really, really big difference. And so what we're going to do now is just find this case link. So here is this one, and I'm going to add that to the chat. If you guys can just open this one. So what I'll do, I'll open it here. And I'm just going to give you guys a couple of seconds to look through this one. Like a couple of seconds, like a minute or something, just to go through that one and tell me what you think. And what I'll do is I will go through the case as well. So it's just downloading right now. Okay, so this is another situation where someone has come in with acute abdominal pain. Let's go from the very, very top. What are we looking at? We have got a contrast enhanced study, like we said before. We know it's portovenous study because we can see that the portal vein is slightly brighter than the aorta over here. And then we just go through what would cause abdominal pain, what would cause a serious amount of abdominal pain. And the amount of abdominal pain could happen from the gallbladder. The gallbladder is over here, and that actually looks completely normal. Doesn't look like there's any fat stranding around there. The kidneys, how do the kidneys look? So kidney is over here, next kidney is over here, and they don't look particularly inflamed. Okay, so that's good. We don't have any problems with the kidneys. And then the pancreas could be causing pain, couldn't it? So you have a look at the pancreas that's sitting over here, and you can see the pancreas looks completely fine. There's not any fat stranding around this at all. Okay, so we've ruled out the gallbladder. We've ruled out the possibility of this being cholecystitis, pancreatitis, inflammation of the kidneys, and we've ruled out the possibility of it being renal tract obstruction. So then what you need to do is really work your way from the rectum upwards. So you can see my mouse is sitting over here, and what we'll do, we'll go all the way up like so, come up to this level over here. We're following the bowel, and this is a skill in itself and something that you sort of get practicing as time goes on. You can see this bowel goes this way, and everything about this bowel actually looks okay. Looks okay so far. Okay, someone's come up with a good answer. Excellent, good, well done. We'll kind of follow this along. And you know what? The one thing I'd say is that if you ever get lost, if you ever think, oh no, I don't know where the bowel is, your constants are the ascending and descending colon. The ascending colon, the descending colon is over here. So work from here. You can kind of feel it going across this way, going across this way. So that's transverse colon, going across like so, going across like so, all the way to this point. And then you feel like it goes down this way, doesn't it? So you feel like the bowel is somewhere here, right? So that's bowel. You're coming up to the ascending colon down this way, down this way, down this way, down this way. But has anyone noticed that it looks like there's like two bits of bowel next to each other? So if you come up to this point, you can see that there's a bit of bowel here, but it looks like there's a bit of bowel here. So someone has said something, and maybe everyone can see that, they said inflamed appendix, which, yeah, you know what, you may be basing that on the idea that there is inflammation located within the right iliac fossa. But there's a little bit more to the story, and I hope that you can take this a little bit further. So yes, there is inflammation located within that right iliac fossa. And then as you kind of scroll upward, you can see that this area over here kind of comes up like so, goes forward, and then there's like what looks like a second bit of bowel sitting just lateral to the actual bowel, and then it kind of just disappears. Can you see that? So that goes all the way down there like that, and then continues into the cecal pole, but superiorly it just stops. Is this whole thing an appendix? Is that what's going on? Well, actually it's not. Appendix should be like a tubular structure, shouldn't it? But this is like a weird kind of cylindrical, almost triangular appearance, and there's a few locules of air within it. Lots of fat stranding. So for those that don't know what fat stranding is, you can see all this fat stranding around there like this. That's abnormal, right? So that is inflammation. So therefore, this is a perforated appendix, exactly like someone has said. But is it a perforated appendix? Is it still a perforation? It's actually a collection, so it's a contained perforation. But actually, what you need to also do is if you go to the lung windows, and I'll do that by going to this area over here, going to lung windows, and scrolling up and down. you've got to try and look for where there's any further locules of air that are free sitting over here. See that? There's a bit of free air sitting over here. And then like maybe a tiny bit of air sitting sort of further up in the abdomen. Hang on, where can I find it? So I saw a bit of a dot there, maybe a tiny dot there. But this clearly is like a perforation, right? And so therefore it's a contained perforation of an appendix. Right, so then what we'll do is go through case number 3. I'm going to just put that into the chat. Pull that across, Control C, and then put that across into the chat. Oh no, let's do this case instead. Sorry, that's not the one I wanted. I'm going to give you a much better case than that, because it turns out some of you guys are quite good. So let's give you something a little bit more challenging. Okay, so let's copy that into the chat. Okay, let's have a look at this one. Don't worry, I'll go through it with you guys. Actually, let me just come out of that, and then, yeah, okay, fine. Okay, so let's go full screen on that, and then open that. So yeah, as soon as you think you know what's going on, do tell me what you think is happening. So this looks like, so we spoke about contrast versus non-contrast. This looks like a non-contrast scan. And what we'll do is work our way through. And the reason I know it's a non-contrast scan is because do you remember on the previous scans, the aorta looked kind of bright and the portovenous system looked kind of bright. But in this situation, it doesn't look bright at all. Okay, so that's fine. Okay, so it's a non-contrast study. Also, you might have noticed that the table is sitting over here. So they're sitting on they're lying on their front. So therefore, this must be a CTKB, CT kidney, ureter, and bladder, looking for renal stones, right? So we've got abdominal pain, we're looking for renal stones. But let's just go from basics. It's a non-contrast study. What could be causing inflammation and pain? Gallbladder, how does that look? Looks fine, okay? Pancreas, can we see the pancreas? A bit difficult on the non-contrast study. You'll be sitting around this area over here, over here, over here. That looks fine. So we're not worried about pancreatitis, okay? So now let's look at the kidneys. The kidneys sitting over here, kidneys sitting over here. And you can see there's a few stones here. You can see there's bright areas over there. They're kind of little starry-eyed little things sitting over here. So there are a few renal stones. So you think, okay, so if someone's got renal stones, we may be looking at a renal colic. But actually, you can see there's a lot of normal renal fat, renal sinus fat sitting within the kidneys as well. So we're probably not looking at renal colic, but it could be the case you've got renal colic. And so what you've got to do, and this is a bit of a nuanced thing, is to follow the ureters going down. Follow them going down. That's ureter, and that's ureter over there. Follow the down. And actually, generally speaking, if you're just started, you just want to follow one at a time. So let's do one at a time, going down, going down, going down, all the way to the urinary bladder, which is sitting over here. Everything looks okay. So it doesn't look like a stone. And if you're ever stuck, you work from the bottom this way, all the way up, and go all the way back up to the top and follow that ureter. Let's follow the left ureter. Left ureter is where? So let's follow that. Coming down, coming down, coming down, coming down, coming down, all the way down like so. You're just going to take my word for it. It's somewhere down here and then going into here. We haven't seen any calculus located within the so a few people have come with some really good answers. You guys are really good. I've got to say, you guys are really good. A few people have been stumped by this one. So look, bilateral renal calculi, you're completely right. Yes, there is a hyperdense lesion located within the kidney. For those of you that haven't seen it, it's sitting over here. But hyperdense kidneys don't cause pain, and renal calculi, which are still in the kidney, don't cause pain. But we've got someone who's got pain, and someone else has come out with the answer. So what we'll do, we'll work from the bottom, quite literally from the bottom. Let's go from here and see what's going on. So someone has said the answer, but there's a little bit more to think about than that. So this is the rectosigmoid junction. Let's get the marker over here. And then you can see that it kind of goes this way like so. And you feel like the bowel goes this way, maybe. God, it's going a bit difficult, it's a bit about, and then it feels like it's going down again over here. God, it's going this way maybe, and then looks like maybe goes this way, right? And around here, can you see this all this fat stranding, a bit like that last case that we had, right? And this area of bowel, what is that? So we follow that, follow that, follow that. Oh, yeah, okay, so it's kind of going up into the descending colon. So this must therefore be the sigmoid colon. So there's a lot of fat stranding around the sigmoid colon. That generally means there must be diverticulitis. Does this person have diverticular disease? Yeah, I think they do have a little outpouching here and here and here, but someone said uncomplicated. The reason why I assume you say uncomplicated is because there's no collection. So what you're looking at is an uncomplicated diverticulitis. We're done, let's move on. But actually, you may have a perforated diverticulitis. And I think that's what you have here, because if you go all the way to the very, very top and go to the lung windows again, can you see the lung finishes here, right? But then some more air is underneath the hemidiaphragm over here. Can you see that? Just there. And as you scroll through, they actually realize, oh, there's a bit of gas there, maybe a little bit of gas there, a little bit of gas there, a little pot, like locule of gas. Can we see any more? Maybe some there, tiny little dot that pops up in that area there, maybe somewhere there. And look, there as well. There's like loads of tiny little dots just of air. So what's happened? Is this complicated or non-complicated? Well, actually, this is a diverticulitis with a perforation. They probably sat around for quite a while with this perforation. They've ended up gathering a whole lot of air within the upper abdomen because they tried to walk around, lie on their side to try and help with the pain. And then maybe it's sealed off, but they've actually got a complicated diverticulitis, not just a normal diverticulitis. So you can see like how, like sort of, so we've been through, let's just, I don't know what that is. Let's get rid of that. So we've been through sort of 3 sort of cases now, going through sort of how you can use basics, like basic imaging, foundation knowledge, to be able to work through quite complex problems and not just find the initial problem, take a step further, and actually give a lot of value from your opinion. And believe me, your opinion really, really does matter. It doesn't matter where you are in the care of the patient, your opinion matters. So our course, why do I think it's really great? We've got core knowledge that we give you the core principles to work from. We give you practice cases, which aren't sort of your normal cases. These are hard cases like the ones I've given you, and not textbook. They've all got learning points that we've very much thought out, and we'll give you feedback. Because we keep it sort of small cohorts, we really work with you, right? So there's no reason to be worried, no reason to be feeling that you're judged. We go through and we really give you as much time as possible to manipulate the image as much as you need using Collective Minds radiology platform that we've just gone through, which is a very, very powerful platform that we use and work together with them to make this happen. And so I think that, you know, we do give a lot of value. And so when you look around at our sort of competitors and other people that offer similar things, you know, 1-day course would cost you in the region of £500. Getting, you know, small group cases would be a second day with live feedback, which would be another £500. Getting access to the on-demand stuff as well, the post-course material, pre-course material is like £200 in terms of value. And then getting on-demand access as well can cost some more money as well. And so generally speaking, when you're looking at what we're offering, you're probably looking at about £1,350 worth of value, but we're actually doing it for about £297. And we keep a very, very small cohort. So we do really make sure that you get the most value possible. So this is where I give you a little bit of a gift for sitting through me talking as much as I do. For the next, you know, up till about 8 o'clock tomorrow evening, we've got a Web 10 discount for this particular course. It is the, if you go to radiologyseminars.co.uk, and I'll just show you now where to find it. And actually, we've moved on to the .com, by the way, so because we're moving up. And so even if you go to the .co.uk, you will end up on the .com. You go to all courses, or even on the front page, find the acute CT body course, and you can just, when you go into this, type in Web 10, it'll give you a 10% discount. That's only available until 8 p.m. tomorrow. So I really, really hope as many as you people, many of you guys can come and join the rest of your colleagues who are joining us for that day. A big, big thank you for everyone that has sat through, going through some hopefully interesting cases. Hopefully you have gained some knowledge from today. And I'll just open up to any questions that anyone may have with regards to any cases or anything in general with regards to radiology, you know, anything. I really don't mind. And if not, then I just have to say thank you. So I'll just give you a couple of seconds. If you've got any questions, please feel free. If there's no questions, it doesn't look like it. Cool. So I think a few people have asked for whether they'll be able to access this later. Yes, we'll most likely add this to our Radiology Seminars web channel. Please go to the website, the channel, YouTube, and type in Radiology Seminars. You'll find loads of our other talks on our main website. There's loads of free talks as well. Loads of people seem to love it. So do sign up, join the mailing list where we're constantly trying to improve things. And if you've got any feedback about this, send an email to info@radiologyseminars.co.uk and let us know, you know, whether you thought it was useful or not. So with that, I really appreciate it. Thank you so much for coming. And I'll hopefully see you guys on our course, our seminar. All right then. Bye.